Hi, welcome everybody.
Hi, everyone.
So, Dr. Horn,
And Dr. V.
and we're continuing our MD Stewardship webinar. Today's topic is going to be HIV and STDs, and we're going to do this in a two-part series. So today we're going to mainly cover HIV, and then next talk we're going to have on STIs, including gonorrhea, syphilis, chlamydia, and that's going to be a great talk as well.
Next month, we're going to talk about pregnancy and infection. So we'll make sure to include some of this because I know we have been struggling with syphilis and penicillin shortage as well. So we'll address that next month.
But HIV is a good topic for webinar. I don't know that we've really had it as one of our topics before, but I think it's a good topic. Most HIV clinicians, most people that treat HIV are actually family practice and primary care providers. So here we'll get started. And if you have any questions during the presentation, go ahead and type it into the chat and we'll answer and address any questions that you have. All right.
So just a little information about HIV. So an estimate of 1.2 million people in the US have HIV, including about 158,000 are unaware that they have HIV. And nearly 40% of new HIV are transmitted by people who don't know they have the virus, unfortunately. The testing is the first step in maintaining a healthy and preventing HIV transmission. You know, one of the other things that I find a lot of people don't know is that a CDC recommends HIV screen at least once in your lifetime between the age 13 to 64. So 13 to 64, at least once. And I've been pretty shocked because I've been talking to a lot of providers and a lot of people don't know that. So you have to start as young as 13, at least one time. And then of course, people who are at higher risk, then at least they should get once a year. Recently I worked with some of our healthcare facilities, and we have made sure now part of our EMR system, it alerts all the primary care providers to at least check for HIV once, which is really important because we're finding out there's a lot of newly diagnosed HIV in the hospital. When it's too late, they're presenting with AIDS and they've never known. So I think awareness of testing is going to be really important.
Yeah, and it's really good to, when you think about that, it's testing at least once, and that's regardless of risk factors.
Yes.
So not taking risk factors into account at all. And part of that is because people don't share the risk factors sometimes, or they don't want to come in and ask for a test. So just, what we say is we're happy to test. The CDC recommends testing everyone. And so that's the recommendation. And so we'd like to do that. And they may, and we tell them, we recommend testing, but testing itself can be cause anxiety. So we try to just tell them, this is we don't suspect it. It's just recommended for everybody. And we like to follow the recommendations.
I sometimes tell my patients because they get scared when they hear that. I'm like, it's just like, you have to have colonoscopy, you have to have mammogram. This also needs to be once in your lifetime checked. But then of course, you have higher risk factors. We'll talk on the next page.
Yeah. And when we test people we have a lot of learners, residents, and fellows. And, sometimes we'll recommend an HIV test and they'll say, oh, but they're married, or oh, but they're, but they go to church. And really the recommendation is to test regardless of all of those things. And so, and there are studies and things that say that people that go to church get tested later, or they get diagnosed later, and when it's advanced. And so there should be, I think it should be really easy and simple to have a test.
Yeah. So sometimes which patient should get tested for HIV if they're higher risk? So everybody should get screened. Also, who are at higher risk? So men who have sex with other men, anal vaginal sex with someone who has HIV, more than one sex partner since your last HIV test, shared needles and syringes and other drug injection equipments, for example, too.
And then diagnosed or treated with another STD or STI. So if someone has gonorrhea or chlamydia or syphilis, really you should be testing for lots of STDs. So it's important to test for other STIs to make sure that, because sometimes they kind of travel together. So it's a good idea, and that would say that they're at high risk, right?
And then if you have hepatitis and tuberculosis. So tuberculosis is really important. When I learned this a long time ago, number one cause for patients with HIV who die are because of TB worldwide.
Right. Yeah.
So then
Yeah.
if you do see a patient with TB, we also then have to think about, we need to make sure we test for HIV. So that's really important.
Yeah, most people with HIV die of TB.
Yeah.
But that's mainly in African countries, but
it's
the
still
risk
the
is
number
there.
one.
Yeah.
So it's really important to know.
And if anytime someone comes in asking for an STI test, it's recommended to do those tests for them.
Yes.
Because I wouldn't try to talk them out of it and say, what are your risk factors? Oh, you're not at risk. It's better just to do the testing if they are asking for it.
And other little caveat for all of you to know too, let's say you have a really sick patient in the hospital, right? So for me, what triggers me to check for HIV, if you're getting recurrent shingles, if you're a young patient, recurrent shingles, if you have history of other sexually transmitted diseases and then that history in the hospital, you want to probably, another thing that triggers me is TB, but also strep pneumo infections. In young patients and things, that should also automatically also think about, should we also make sure we test for HIV?
Yeah, that's a really good point, because the people in the hospital, when you think of testing the general population, there has to be a certain number of the disease in the community, but the test should be cheap, it should be accessible, it should make a difference in their care. But when you think about testing people in the hospital, that's a different population. That's not your average, a randomly chosen person in the community. That's a person in the hospital, and if they're in the hospital with an infection, then I would recommend testing them.
Yeah.
Most people that get diagnosed with HIV, they've also seen a clinician sometime in the last, I think it's 3 months.
Yeah.
They've seen someone, and sometimes they'll, if you look back on the people that are newly diagnosed, you can say, oh, they have been seeing a clinician, regularly for different problems, or they've been in the hospital. So if someone's in the hospital with infection, and they haven't had an HIV test and recently, then it would be a good idea to test.
And those infections that triggers recurrent shingles, young patient with shingles, hepatitis, tuberculosis, and strep pneumo, and of course, a history of other sexually transmitted diseases as well. Here's just nice data about estimated HIV infection in the United States over time. So every year, it's decreasing overall. But you see from 2021. But what I'm hearing is, though, when I talk to our health departments and stuff, because during COVID-19 pandemic, a lot of the STI clinics got shut down and all the resources were pulled to do other things. It's not really technically decreasing. We just haven't tested enough people. So there's more people that are like undiagnosed. So it's really important now more than ever to make sure we're checking and diagnosing folks.
New HIV diagnosis in the United States by age. And so, let's see.
And it breaks down nicely the different age group.
Yeah, so it's mainly 25 to 34, but there's still new HIV diagnosis in every category.
And they're also noticing some trends now that they're seeing more HIV diagnosis in rural communities as well. So there's a little trend, especially in our state, I was talking there. So things to kind of keep in mind and making sure.
And I think these are new HIV diagnosis, but the people living with HIV, since they're, it's well managed, the overall number of people with HIV
is
going increasing or stable.
So, we still have patients who have AIDS, unfortunately, and they get opportunistic infections or other conditions, AIDS defining illnesses, and they're still passing away. So, you could see male to male sexual contact, number of death over 300,000, IV drug use of 150,000, both MSM and IV drug use 63,000, heterosexual contact 50, perinatal 754, and other. So, I always say in this day and age, we have such amazing antiretroviral medication. Like, we shouldn't get to this stage. So
Right.
that's why it's so important that we prevent getting to AIDS and keeping our patients virus suppressed and keeping the immune system strong. And this is just by region.
Oh, by region, by area of the country.
Yeah. So if you look at Northwest, Midwest, Southwest, and just West, you could just see the different regions where the predominant people who are dying and where we need to focus more as well. And yeah,
this is amount in the blood. So this is time since infection. So when someone's infected, the HIV RNA, the viral load increases and it goes very high. And then it comes down a bit and stays about stable. And the HIV antibodies, antibodies are made. And then you see the antibodies and then antigens. And really, that's important because that's what we use to diagnose, would be antigens and antibodies.
And now they have the 4th generation testing. Yes. And I think many of all of us have moved towards that. 4th generation testing, if you look at the bottom line, it's now as good as HIV viral load. It's much sooner. So it's antibody antigen testing, which is really good. But of course, always you have to do a confirmatory test. HIV viral load is what we always do. But viral load, as you see, takes about 10 days to show up. So does 4th generation. So having both would be really helpful.
Right. And the old textbooks would say, if you're not sure, to test again in 2 months or something. And if you just get a viral load, that will solve that. So you don't have to say come back in 6 weeks or something.
Yeah, because within 10 days of exposure, you're going to have viral. Yep. Yeah. So this is the algorithm for testing now. And I think many have adapted to this. So the HIV-1 antigen antibody combination assay. It goes back to that picture about how it shows up early. So if it's negative, you could stop. But if it's like HIV antibody differential immunoassay, then you could have different times, like HIV-1 is positive, HIV-2 is positive, both are positive. And then of course, if it's indeterminate, then you could do the NAT test too, as well after that.
And primary HIV infection. So 50 to 90% are symptomatic seroconverters. Illness begins 1 to 4 weeks after exposure. And clinical features similar to acute Epstein-Barr virus. So Epstein-Barr, a lot of people with HIV, they'll get a pharyngitis. You can get, some people might say, oh, they're suspecting strep throat or something like that. Or mono. Yeah. So and that's malaise, fatigue, muscle soreness, maybe a bit of a fever. And sometimes when this happens, a person will go to the hospital and then they'll get worked up and they'll say, we can't really figure out what it is. It was some kind of viral illness, and they may go home on azithromycin or levofloxacin or something, just for a few days. And then when we talk to the patient, when they're diagnosed with HIV, they'll say, we'll ask them, have you been in the hospital, in the last 6 months to a year? And they'll say exactly that. I was hospitalized. They said it's probably a viral illness. And sometimes they'll say, oh, they test me for HIV, but it was negative. And that's in the past when they would just check antibodies. If their antibodies weren't created by that time, then we'll say, oh, they will think that it would have been better to check viral load. But now that we have, they check virus plus antigen testing, hopefully it
Yes.
doesn't happen as much.
Yeah, I hope so. But the problem is people don't think about it.
Right.
So that's what we need to make sure we think about. Like, this is like, it could be acute HIV and we're missing.
Mono and pharyngitis. Yeah. So if I ever hear there's a 23-year-old with pharyngitis symptoms, and they'll say, oh, they did a strep throat and that was negative, and they did, they'll do somewhat of a workup and they can't figure it out, we'll also recommend HIV testing. Yeah. And I would do that regardless of what they talk about as far as their their history has been. But whenever we discuss history of their social history, we always have the family and the mother and the father step out of the room and discuss it just with the patient.
Yeah, that's really important because
they won't be honest.
Yeah, they won't be honest, and they feel awkward.
Yeah.
They so it's really important to like have that privacy. You could talk to the patient, and just like we talked about fever, fatigue, rash, headache, pharyngitis-like symptoms, and then of course night sweat, sometimes aseptic meningitis, oral ulcers, GU ulcers. And then you could also see sometimes like lab abnormalities too. And I have seen low platelets, I've seen low white cells, I've seen also elevated liver functions. So these are all can be clues, tools to make sure we diagnose the patient.
Yeah. And even if the patient says, no, it's okay if my mom or dad stays, I say, no, you really need to step out of the room. And I say it's our policy to have all family members leave the room. And here's acute HIV rash. Now, the acute rash, the patient may not notice it or may not know that they have it. So it is important to look at their skin. And it doesn't happen with every patient, with every new HIV, but it can happen.
Yeah, and sometimes it can be itchy, but it can definitely happen.
When to start ART?
Yeah, so it used to be a long time ago, when to start antivirals, right? And they'd be like, wait until the CD4 count drops so bad and then to start. And we have learned over the years that's a bad idea. So the thought is that when you're diagnosed with HIV, as soon as you can, you should be started on antiretrovirals. Other caveat, a small caveat, is if a patient presents with AIDS, so AIDS defining illness, sometimes you have to hold the antivirals because you could cause this inflammatory reaction, but that's only for when patients have AIDS. But if you have newly diagnosed HIV patient, teaching and starting therapy as soon as you can is the best thing we could do for the patient.
So as soon as the diagnosis, increase the uptake of, and that's antiretroviral therapy, and you get them linked with care, decrease the time to viral suppression for individual patients. So yeah, as soon as they're diagnosed, you want to look into starting, and the first meeting with an HIV patient, like in clinic or when you start, the goal really is to look at all of the barriers to care and see if you can eliminate the barriers to care. So, and even things you may not suspect. So, can the patient read? That if they can't read, they may not be able to take the medications. Are they able to, do they have transportation to get to the clinic, right? So you want to see all of these things, are they homeless? Who are they living with? How do they get money? Are they willing to start? If not, why? And you kind of, I think of the first meeting, as building rapport with the patient, making sure that they trust you and that they're willing to take medications, and figuring out what are the barriers to care and kind of knocking them down.
Another misconception is, even from providers and healthcare providers too, and healthcare workers, is that it's too expensive and patient can't afford it. So important thing to know is insurance cover it. If the patient for some reason doesn't have insurance, then there's programs that give patient free medicine, programs such as Ryan White programs. So for example, in Nebraska, when my patients don't have insurance, we go through Ryan White and my patients get their antiviral medication for free every month. So a patient should never go without their medicine because there's always a way to get it. The other thing that you were saying is, I like the viral suppression. The reason is the longer the virus replicates in your body, it causes so much inflammation. It decreases your immune system, but it also like affects your coronary arteries and so you get diabetes, heart disease, all the other chronic illnesses. So soon as we get viral suppression, better is for the patient, long run.
An initial evaluation for HIV. So, and there's a very good website for all of this information where they actually break it down and they have graphs of, initial diagnosis, what to check, and then how frequently to check different things.
AIDS.nih.gov, AIDS guidelines, and HIV guidelines.
AIDS info.
Yes.
AIDSinfo.gov. I think they actually changed it recently.
Did they? Okay.
But if you look at AIDSinfo.gov,
yeah.
Viral load, CD4 count, a TB test, 5701, and then other STIs, HIV resistance testing, toxoplasma serology,
and G6PD. So the HLA-B 5701 is because if that is positive, you can't use certain type of abacavir. Otherwise, you could have a life-threatening rash. So you have to make sure you check for that. And G6PD is if you have a patient with AIDS and you cannot use Bactrim for PJP, then you need to put them on dapsone, for example. So you need to check for G6PD. So if you get all of this done in the initial visit, you have all the data for later on when you need it.
And antiretroviral therapy, the future. So in the past, HIV was discovered, and then zidovudine monotherapy, triple drug therapy, single tablet regimens, integrase inhibitors, long acting. So yeah, they used to take handfuls of pills, and that's also with the first meeting with the and diagnosis of the HIV patient is discussing with them that it's not like it used to be, because people will think of this as a death sentence or something. I don't use those words with patients, but it's actually a chronic illness now, and it's something that can be managed extremely well, and it's just one pill a day, or now just injections rather infrequently. It's not all of these pills that are really hard to take. They're actually tolerated extremely well, and the patients, most patients don't even know they're on them when they're taking them. They don't feel any side effects, is what I mean. And there are actually a lot of drugs now for it, right?
There's a lot of drugs, and there's a lot of different categories of drugs. I love integrase inhibitors. When I started and when the integrase inhibitors came out, they're wonderful because they have low threshold. They don't have resistance. So even if you miss, we don't want people missing drugs, but they don't mutate as much as the other drugs. So integrase inhibitor has become the big agent that we all use now for our patients.
Three drugs in antiretroviral therapy. So you want to use 3 drugs at a time to reduce the likelihood of getting resistance to any one of them, but 2 NRTIs and a 3rd drug. So you can use integrase inhibitors are excellent.
So like usually the backbone are always M-tricytidine and tenofovir, or bacavir and lamivudine. Plus, it's mixed in with one of these, but usually what we end up using a lot is M-tricytidine, tenofovir, and an integrase inhibitor. And they come one pill, and it's amazing, right? One pill once a day. So we really emphasize to our patient the pill burden is just one pill. And then I also help them make sure you set an alarm clock on your phone if you forget. Make sure you keep it by your bed so you could remember. Just giving them that extra. And sometimes, we actually get a pill box and fill it in monthly for some of our patients so that they remember. So anything that we could do to help our patients.
And then, as far as the AIDS info, as far as those recommendations, they'll have what to start. they'll have what to start, what not to start, and they simplify it very well, and what to look for each one. Yeah.
And all of these drugs have the tenofovir emtricitabine or abacavir lamivudine plus an integrase inhibitor, the first agent, and they all come one pill once a day, so which is fantastic.
There are a lot of single tablet regimens out there now. Yep. And then the recommended, and this is cut right from the HIV guidelines. They'll make recommendations, and they'll put for people who do not have a history of use of different things. But really those guidelines, and they get updated every few months, and then it'll be they'll have something highlighted saying this was last updated, and it might have been a couple months ago. They're updated frequently. So that's one of the benefits. Anything in print is probably out of date, because even if you printed that a couple months, it's going to be out of date.
And we just printed it to show what we showed earlier where we got it from.
Okay.
So another thing to know is that we always get called about, like, when a patient
needle stick injury.
Like healthcare worker had a poke or some sort of post exposure, right? Unfortunately, sometimes there was sexual assault and things like that, and you don't know. So what you have to do is, while you're testing the patient, you have to give 28 days of post-exposure prophylaxis. And again, the recommended for post-exposure prophylaxis is an integrase inhibitor, either ratelgavir or dolutegravir, plus Truvada, which has emtricitabine and tenofovir. So we give that for 28 days. But so this is post-exposure prophylaxis. So anybody that needle stick and other type of exposures.
And if you're not sure, it's better to start it.
Yes.
And then you can always stop it later. But these are tolerated very well. So people, they'll worry about starting it and having side effects for 28 days. But actually, they're so good.
Yeah.
They're probably not going to have any side effects from starting these medications.
That's really important, what you said too. Another thing to remember is also post-exposure. Let's say a healthcare worker had a needle stick. Best is to start the treatment as soon as possible. So in your healthcare facility, having your policies and being able to get to the medicine within the first 2 hours is the best practice, but they actually recommend even up to 72 hours. So you have to have policies in your employee health to get it as soon as you can for the patient.
Yeah, because if they're not treated within the first couple of days, then the recommendation is not to give them anything.
Yeah. And the reason that you want to start is that when you're exposed, and if you do have viruses and they're multiplying, they're not getting into, for example, the lymphoid tissues and stuff, right? And you don't want them to get into that tissue to become
set up reservoirs.
Right? Yeah. So you got to give it as soon as you can, your post-exposure prophylaxis.
So that was post-exposure. So if they've already had an exposure, but what about pre-exposure? So these are pre-exposure prophylaxis are for people that may have or they're high risk of having exposure in the future, or for couples that are discordant couples. So one partner in the relationship has HIV, and those couples we would discuss and we counsel and when we see them in clinic. But so people with ongoing risks of HIV, we would recommend taking, and this has a combination of 2 antiretroviral drugs and a single oral tablet. Truvada is what's usually given. And the recommendation is to continue it and take one daily. Although even if people take it on like a Saturday before they go out to party or whatever, it still helps, and it still prevents HIV transmission.
Yeah, not as high as, but it still works. But what they recommend is, like, if MSM, multiple partners, or like, heterosexual multiple partners. If you're working in the sex industry, IV drug use, doing pre-exposure prophylaxis is really helpful, and it prevents 99% effective at preventing HIV acquisition.
And HIV, but not other STIs.
Yes.
So they still want to use precautions, and they still want to be safe. But 99% in preventing, and this is just HIV.
HIV from sex, and 74% for IV drug use. So a lot of people need to start doing more of it. And
Yeah.
there's not enough awareness. So CDC really wants this program to become robust. There's enough data now, so that primary care providers, everybody is providing this for the patient.
Yeah, and the goal here is really reduce those new HIV diagnosis
Yes.
patients that we were discussing earlier. So what kills people living with HIV? The cause of death in AIDS.
Yeah, so past and current, right? So in the past, we had opportunistic infections,
like PJP.
Yeah, PJP, pneumocystis pneumonia, cryptococcal, disseminated infection, cytomegalovirus infection, MAC, Mycobacterium avium infection. We still see those, but it's rare.
Mhm.
But now what's really hurting our patients living with HIV is coronary artery disease, heart disease, high blood pressure, heart disease, stroke,
Mhm.
So
And that's from all the inflammation that you were describing earlier. Yeah.
inflammation. So that's why it's important to start antivirals earlier,
Mhm.
but also lifestyle. We're finding a lot of HIV patients, higher risk for using tobacco
Yeah.
and alcohol. So all those count, and weight gaining. So like
And it
healthy
affects them
diet.
more, right?
Yes.
So if you have a smoker with HIV and a smoker without HIV, the smoker
Yes.
with HIV is more likely to
Yes.
get complications like from smoking, like cancers or heart disease for sure,
Yeah.
and get the problem. So it's really important now. We're recommended to, when you talk to a patient with HIV during that visit, you're supposed to ask them, do you smoke cigarettes, and counsel them to stop smoking, because the people with HIV are dying from smoking, right?
Yeah.
Well, I mean, the people that smoke, patients with HIV that smoke are more likely to have complications from the smoking than they are their HIV, which there are articles about lives lost, or sorry, years lost,
Yeah.
from
I have that.
from patients with shortened lifespan.
Yeah.
And it's not from HIV, it's actually from smoking.
Yeah.
So more patient years, like life years, are lost from smoking than HIV in patients with HIV, which really highlights how well HIV can be controlled now, right?
But again, the key point is general population smoking without HIV, but HIV and smoking higher risk, and shortens your lifespan by 6 years, far more harmful than well-managed HIV. Major risk factors for coronary artery disease, high cholesterol, so a lot of patients actually need cholesterol managed really well as well.
Okay, so that's everything for today. I hope you found that helpful. HIV continues to change pretty rapidly. The medications continue to change and update, and the recommendations for testing and the and diagnosis, each of those tests. So it would be good, the micro labs, we try to stay up to date with our microbiologist in our lab as far as what HIV tests do we use to diagnose, and making sure that those are as up to date as you can get them.
Yeah, and I think also having a low threshold to screen. So like I think all of you going back to your facilities, making sure like there's some sort of protocol that everybody 13 to 64 should get checked for HIV in your outpatient setting. And then also having higher degree of awareness in the hospital setting, those conditions we talked about, shingle, strep pneumo infections, recurrent shingle, strep pneumo, tuberculosis, other STI, hepatitis, if they have those, making sure that we check in the hospital for those type, not everybody, but those type of high risk patients. And then of course, making sure that patients know there's resources. A lot of times when patients come to us, they're so afraid they can't afford the medicine, and just telling them, no, we could get you the medicine. If you don't have insurance, we could still get you the medicine. So I think those are all key takeaways. Any questions at all that you all have on HIV?
And if you have any protocols like post-exposure prophylaxis, like needle stick injuries, or if you want more information about pre-exposure prophylaxis, we'd be happy to work with you about protocols and getting any of that information. And, we're always available in case you have any questions, as it happens. Feel free to call us and ask us any questions about any patients that you're seeing.
Well, thank you all.
All right. Thank you, everybody.